Hey, welcome back. So we'll start with the third module of the day. So we'll be talking about truncal blocks and spine sonography. Our next speaker is a Sabahan-born gentleman who did most of his early service in Sabah. After completing his master's in 2015, he was an anesthetist in Hospital Ampang and HKL. He completed his fellowship of regional anesthesia at Khairul University and has been a facilitator for regional anesthesia workshops since 2017. Welcome to the floor, Dr. Khairul Idzam.
Assalamualaikum and a very good morning, everyone. Thank you, Dr. Sarah, for the kind introduction. I also want to thank Dr. Ku, Head of Department, Anesthesia Department, Hospital Pulau Pinang, Organizing Committee, and Aspen for inviting me as a speaker for UGRA workshop for Northern Region. I'm Dr. Khairul from Hospital Ampang. I did my fellowship in regional anesthesia at Kyorin University Hospital, Tokyo, Japan in 2018. So I just want to share with you this magnificent sunset view of Tokyo from Roppongi Hill, and you can see directly here is the Mount Fuji. My topic today is central neuraxial blockade and truncal blocks. For central neuraxial, consists of spinal and epidural. For truncal, consists of PECS, TAP, QL, and ESP block. So the objectives of the spinal and epidural blocks is to identify important landmarks such as the spinous process, articular process, and transverse process, and of course the posterior complex and spinal canal. To describe an approach to identifying spinal level, midline, and depth to the ligamentum flavum using ultrasonography. So before you can appreciate the black and white image on your ultrasound screen, you need to be familiar with your vertebra. So the vertebra is divided into body and arch. The arch is further divided into pedicle, lamina, spinous process, transverse process, and articular process. Articular process is further divided into superior and inferior. So the vertebral canal is formed posteriorly by the spinous process and lamina, laterally by the pedicle, and anteriorly by the vertebral body. Within the vertebral canal lie the thecal sac, which is formed by the dura mater and arachnoid mater and its content. Epidural space is the space within the vertebral canal but outside the thecal sac. So why do we want to use ultrasound to identify central neuraxial blockade? Because we have been performing spinal and epidural using landmark technique since we are still a baby in anesthesia, right? Without any complications. So these are the reasons why we are using ultrasound, because it is non-invasive, safe, simple, can be performed expeditiously. It is a real-time image, no side effects, and the most important thing is beneficial in patients with abnormal spinal anatomy, such as kyphotic spine, scoliotic spine, and spine of an obese patient. So let's see the evidences. In 2002, Furness published an article in Anesthesia Journal and evaluations of ultrasound imaging of for identifications of lumbar intervertebral level. He found out that 70% of the samples identify the level correctly using ultrasound, whereas only 30% correct by using palpation. In 2018, NICE published an article and concluded that evidence on ultrasound-guided catheterizations of the epidural space is limited in amount, but suggests that it is safe and may be helpful in achieving correct placement. So first, we need to know the proper orientation. There are three: the paramedian sagittal and the paramedian sagittal oblique and transverse orientation. From the paramedian sagittal orientation, we need to turn 90 degrees to get the transverse orientation. So how to identify? Bony surfaces are hyperechoic, which is white line structures with dense acoustic shadowing, which is black beneath that completely obscures any deeper structures. Fat and fluid have very low acoustic impedance and are hypoechoic, which is dark. Where to target? Ultrasonographic visualizations of structures encased within the bony vertebra in adults is possible only through the interlaminar spaces between adjacent vertebra. If an interlaminar windows that permits passage of sound waves into the vertebral canal can be identified, the same window will permit passage of needle into the epidural or interstitial space. So first, we must get our paramedian sagittal transverse process view. We place our transducer, which is usually a low frequency curvilinear transducer, 3 cm lateral to the midline to get this view. So we can identify the transverse process and the erector spinae muscles. Beneath it is the psoas muscle. So this is the level that we are going to scan, and we can identify this structure: the transverse process, the erector spinae muscles, and psoas muscle. We describe it as a trident sign. So trident is a weapon of Poseidon. Okay, so this looks like a trident. Next, we slide our transducer medially to get the paramedian sagittal articular process view. So we slide medially, and then we get this image. We can identify the erector spinae muscle and articular process, okay, at this level. So once again, we scan at this level, and we will get this sonographic image. So we describe this as a camel hump, okay? It looks like a camel hump. Then after we get this view, we tilt our transducer obliquely to get this paramedian sagittal oblique view. From here, we can identify the posterior complex and anterior complex. Okay, so these are the lumbars, and then here are the erector spinae muscles, and we can identify the posterior complex here. And next, this is more clearer view of the oblique view, where we can identify the posterior complex and anterior complex. Okay. Usually, we will start counting the levels from the sacrum. Once we identify the sacrum, then we start to count the vertebral level. Okay. So we describe this as a horse head or sawtooth. Then after we get this oblique view, we need to turn 90 degrees our transducer to get the transverse spinous process view. Okay, so in transverse process view, we can identify the tip of our spinous process, the erector spinae muscles, and the lamina. So this is the level that we need to scan. Okay. So here is the tip of the spinous process and lamina. So this is the acoustic window. Okay, this is another view. The lamina, spinous process, and acoustic view, acoustic shadow. So once we have this spinous process view, we need to slide carefully or caudally, depends on our intended level, to get the transverse interlaminar view. Okay. So in this view, we can identify our interspinous ligament, the erector spinae muscles, and articular process, and also the most important thing is the posterior complex and anterior complex. So this is the level that we are going to identify. So this is another view. in this view, it is more clearly, which we can identify the posterior complex and anterior complex. And of course, between the posterior complex and anterior complex is the spinal canal. Posterior complex consists of ligamentum flavum, epidural space, and posterior dura. So rarely can be seen as two hyperechoic lines, usually only one hyperechoic line. For the anterior complex, consists of anterior dura, posterior longitudinal ligament, and posterior part of vertebral body and intervertebral disc. So usually visible as single thin hyperechoic line. So here we can identify the ligamentum flavum and the transverse process. Sometimes we describe it as a bad sign. Okay. So as a summary, first we're going to get our transverse process view about 3 cm lateral to the spine to identify the trident sign. Okay. Then we slide medially to get the articular process, and here we can identify our camel humps. Then after that, we slide more medially for the laminar view, and we can identify the sawtooth and horse's head. From here, we can tilt our transducer to get the oblique view. Okay, here we can see the posterior complex and anterior complex. Once we identify the structures, then we turn 90 degrees our transducer to get the spinous posterior view or the interlaminar view to identify the posterior complex and anterior complex. Okay. So end of chapter 1. So now we move to the truncal blocks. I will be explaining about PECS block, TAP blocks, QL, and ESP block. So Blanco in 2011 described PECS 1, which involved an interfacial LA plan injection between PEC major and minor, so aiming to block the lateral and medial pectoral nerves. 1 year after that, in 2012, Blanco described PECS 2, which is PEC 1 plus second injection. Second injection is a LA plan injection between PEC minor and serratus anterior muscle at the level of the third rib. So neural supply originates from two main sources, brachial plexus and thoracic spinal nerves. So this is the neural innervations of the anterior chest wall. So for PECS 1, it covers the pectoral nerves, lateral and medial. Lateral pectoral nerves from C5 to C7, medial pectoral nerve from C8 to T1. The PECS 2 covers T2 to T6 of spinal nerves, long thoracic nerves, and thoracodorsal nerve. So here we can see the lateral pectoral nerve and medial pectoral nerve, which is covered by the PEC 1 and long thoracic nerve. This is the branches of the spinal nerves innervating the chest wall. So from the spinal nerve, branches out to the ventral and dorsal rami. The spinal nerves branches become the lateral cutaneous, then anterior cutaneous. So the indications for PECS 2, for extensive breast surgeries such as wide tumor resections, mastectomies that involve axillary clearance, thoracoscopic surgery, and proximal arm vascular surgery. Sometimes we perform for as a supplement for the BBF surgery. Okay. So PECS 1, as I mentioned earlier, this is the original block. Covers the lateral and medial pectoral nerves. The indications, surgeries involving PECS major muscles such as breast expander, traumatic chest injuries, portocade, or pacemaker incision. So how much LA do we need to deposit in these facial planes? Usually only 10 mils between the PEC major and PEC minor. So technique, we need to identify the clavicle, and we start to scan from the mid-clavicular level and angle inferolaterally. For this technique, we are using high frequency transducer, and then we start from the mid-clavicle level, and then we try to scan inferolaterally. We locate the axillary artery and vein, then move the probe laterally until PECS minor and and serratus anterior are identified. Okay, so from there we count our ribs, second and third ribs. So usually we perform PECS 1 at the third ribs level. With the image centered at the level of the third rib, advance the needle in plane from medial to lateral in an oblique manner until tip lies between PEC major and PEC minor. So inject 10 mils in that plane. So this is to show you how it is done. So this is the patient's head. So it starts from the mid-clavicle level, and we slide inferolaterally. Here we can identify our PEC major and PEC minor. So we need to deposit our LA between these planes, but be careful of the artery. Okay. So this is another image. This is the patient's head, cranial caudally in plane using high frequency transducer. So after we identify the third rib, we try to deposit our LA in between PEC major and PEC minor for the PECS 1. So PECS 2 is a modified block. So it blocks the spinal nerve, T2 to T4, including intercostal brachial nerve and long thoracic nerve. So indications, more extensive breast surgery involving serratus anterior and axilla, such, for example, tumor resection, knot excision, axillary clearance, and tissue expanders. So how much LA to deposit? Usually 20 mils. This is a facial block, so we need much volumes. So we need to dilute our LAs to become less concentrated. Okay, so we inject this LA between PEC minor and serratus anterior at the third rib level. This injection aims to enter the axilla to reach the target nerves, but LA will not enter the axilla if the fascia on the pectoralis minor lateral border is breached by surgery. So post-operatively can be challenging if you perform PECS. So ideally, we need to perform PECS block pre-operatively. Okay, so the technique same as PEC 1, but we also need to identify the potential space between the lateral extent of the PEC minor and serratus anterior. Okay, so first we perform PECS 1, but usually, personally, I usually perform second injection first, then I withdraw my needle to perform PECS 1. So this is the sonoanatomy. We need to identify our muscles, PEC minor, PEC major, PEC minor, and serratus anterior muscles. This is the third rib and the fourth rib. This is the pleura. Okay, you must be careful of the pleura. Then for the second injection of PECS 2, we deposit our LA between PEC minor and serratus anterior muscles, and then we deposit 20 mils of LA and withdraw, and we deposit our LA between the major and minor. So this is to show you where is the LA being deposited. This is at the fourth rib level. Okay, so first we inject second injection of the PECS between the serratus anterior and PEC minor. Okay, 20 mils, and then we withdraw to deposit our LA between major and minor. So yeah, we need to be careful of the artery over here, okay, between the PEC major and minor. So the dermatomal level, PECS 2 usually covers from T2 till T6. So what are the evidences? Sopena Zubira et al. Did a study to compare PECS plus paravertebral block versus paravertebral block. So they found out that in PECS plus paravertebral block, they have better pen score and less opioid consumption as compared to thoracic paravertebral block. Wahba then did a study comparing PECS versus thoracic paravertebral block, and this study he did 60 patients underwent mastectomy, so he found out that it is comparable. Bashani and Abbas did a study, 120 cases of radical mastectomy, both given GA with or without PECS block. So they found out the same. They found out the result in the PECS group, less opioid consumptions and better pen score at 12 and 24 hours. Another another small CREST series written by Parcell. This is just a small case series describing PECS2 for proximal upper limb fistula. So what are the recommendations? PECS2 as analgesic modality for breast surgery. For optimum clinical benefits, PECS plus paravertebral block, but no studies comparing between PECS plus ESP. Maybe we can do this research because paravertebral block is technically difficult. Okay, so if we can perform PECS alone, should be enough. So PECS is performed 10 minutes prior to surgery to allow fixation of the LA to the neural structures before surgical stimulus. But in HKL, we usually perform it post-operatively. Okay? But this is the problem if we perform PECS post-operatively. Ineffective spread or inaccurate planar distribution affecting quality of analgesia as a result of tissue edema. Okay? So next, we move to TAP block. So why do we want to perform TAP block? So it is easy, safe, effective analgesic, minimal hemodynamic effects, and allow early mobilizations. It is an alternative to epidural, provides opioid-free anesthesia, part of multimodal, and less complications. So this is the innovations of the anterolateral abdominal wall that it arises from the anterior rami of the spinal nerve T7 to L1. So intercostal nerves at T7 to T11, subcostal nerve T12, and iliohypogastric and ilioinguinal nerves at L1. So TAP, there are two types, classical and subcostal. Subcostal usually covers from T7 till T9. However, the classical TAP will covers from T10 to L1. Okay? This is why Dr. Zetek just now mentioned in hip surgery, acetabulum surgery, in inguinal approach, he performed classical TAP to cover this area. Okay? So indications, lower abdominal surgeries for appendectomy, hernia repair, caesarean section, abdominal hysterectomy, and prostatectomy. We also can perform for laparoscopic surgery. So the technique, this is a subcostal TAP and this is a lateral, the classical TAP. So for the subcostal TAP, we start from the costal margin, just below the rib, to identify these muscles, the rectus abdominis and transverse abdominis. So we deposit our LA between the rectus abdominis and transversus abdominis. For the classical TAP, we place our probe between the costal margin and iliac crest. So we need to identify three abdominal muscles, external oblique, internal oblique, and transversus abdominis. So we deposit our local anesthetic in between internal oblique and transversus abdominis. So this is the cross section, which we can identify the three abdominal muscles, external oblique, internal oblique, and transversus abdominis. Okay, so here where we want to deposit our LA for TAP block. Another pictures of how to perform TAP block. So this is where we want to scan for the TAP block. This is for the classical TAP, okay? So there are two fascia that we need to know, the thoracolumbar fascia and the transversus fascia, okay? So the transversus fascia runs beneath the transversus abdominis, and the thoracolumbar fascia is more posterior, okay? So first, how to perform classical TAP. So first, we put the probe on the umbilicus. Then we try to move the probe laterally. Here we can identify the rectus abdominis. Okay, so we slide more laterally at the anterior axillary line above the iliac crest and below the costal margin. At this level, we can identify the three abdominal muscles: external oblique, internal oblique, and transversus abdominis. This is the peritoneal cavity. So classical TAP block, once again, this is where our needle come from the anterior posterior. Here we try to target between the the internal oblique and transversus abdominis. Okay. How much to deposit? This is another plan block. We need higher volume, at least 20 mils, 0.2% or 0.3775%. We can see the spread of our AA if we are in the right plane. We can see the unzipping of the fascia, okay, between the internal oblique and transversus abdominis. Once again, this is the tip of our needle between the internal oblique and transversus abdominis, so we can see the spread of our local anesthetic. So subcostal TAP block, puncture in plane from medial to lateral. So we place our transducer just beneath the costal margin with the rib, and we can identify the rectus abdominis and transversus abdominis. Okay. So here is the needle, the orientation of the needle. Once we inject, then we place we inject our local anesthetic between the rectus abdominis and transversus abdominis. Okay. So summary: TAP block does not provide visceral analgesia. Classical TAP blocks will provide analgesia for operations at or below the umbilicus, but if the surgical site is above the umbilicus, we can perform subcostal TAP. Okay, these are facial planes technique and rely on the deposition of large volume of LA. Maximum LA doses must be calculated to avoid the effects of LAS, systemic toxicity. Next is the QL block. There are three types: QL1, QL2, and QL3. QL3, also known as a transmuscular QL or anterior QL. So LA is injected in facial between the QL and psoas major and will spread to somatic paravertebral space. Okay, segmental, somatic, and visceral analgesia from T4 to L1. So the indications: more extensive abdominal surgery such as large bowel resection, open or laparoscopic cholecystectomy, LSCS, total abdominal hysterectomy, open prostatectomy, renal transplant surgery, nephrectomy, abdominoplasty, ileostomy, and laparotomy. So the good thing about QL, it covers both the somatic and visceral pain. Out of the three muscle layers of the anterolateral abdominal wall, the transversus abdominis and internal oblique tapers off posteriorly into the origins from the thoracolumbar fascia. The external oblique ends posteriorly in the free edge, which abuts against the latissimus dorsi. So here are the three abdominal muscles. Then this external oblique abuts become the latissimus dorsi. Okay, so this is the QL muscles. Beneath it is the psoas. Okay. The thoracolumbar fascia. Thoracolumbar fascia is a complex tubular structures of blended aponeurosis and facial layers that encases the deep muscles of the back. Extends from the lumbar to thoracic spine. Splits into three layers, anterior, middle, and posterior. So the posterior and middle layers enclose to the paraspinal muscles. The middle and anterior layers enclose to the QL muscles. So when we perform QL blocks, usually we want to target this anterior and middle thoracolumbar fascia. QL muscles is a quadrilateral muscle extending between the 12 ribs and the iliac crest. So this is the QL muscles. Medial and anterior of the QL muscles lies the psoas major. The transversalis fascia is a thin areolar tissue that lines the deep surface of transversus abdominis and separates it from the parietal peritoneum. A part of the larger endo-abdominal fascia that lines the entire internal aspect of the abdominal wall. Continuous inferiorly with the fascia iliaca and medially with the investing fascia of the QL muscle and psoas major muscle. So when we perform QL block, we must be careful of the kidney and the peritoneum, okay, because it lies very near to the structures. This transversalis fascia follows the QL muscle and psoas major superiorly through the diaphragm, blending with the endothoracic fascia of the thorax. This relationship, these fascias and muscles have important implications for the potential spread of the local anesthetic in the posterior abdominal wall. So the QL also can spread to the paravertebral space. So this is another image of the QL muscles, okay, and the latissimus dorsi. So usually we aim our QL3 in between the QL muscle and psoas muscle, okay, psoas major muscle. So where to scan? So same as our tab block, usually patient in lateral position, we place our transducer above the iliac crest and we can get this sonor anatomy, okay? So we can identify the three abdominal muscles, external oblique, internal oblique, and transverse abdominis. Then we go posteriorly and we can identify the QL muscles. ESM muscles and psoas major. So the most important structures that we need to identify is the transverse process and vertebral body. Okay. So these are the place that we want to inject our local anesthesia. For QL1, we inject between this QL muscles and also the end of the transverse abdominis muscles. For the QL2, the injection is between the QL muscles and also this latissimus dorsi. Okay, latissimus dorsi and QL here. Then for the QL3, which is the transmuscular QL, is between the psoas and also the QL. Okay, so the transversalis fascia lies over here. So what are the differences between QL1, QL2, and QL3? The coverage for QL1 is just below the umbilicus and usually covers somatic. It doesn't cover visceral. So QL2 block, it covers the dermatome from T6 to L1. It covers both somatic and visceral, blocks anterior and lateral cutaneous branch of the intercostal nerve, sorry. So for the QL3, the dermatome it covers from T6 till L1, covers both somatic and visceral, and blocks anterior and lateral cutaneous branch of the intercostal nerve. The site of injection for QL1 is the potential space medial to the abdominal wall muscles and lateral to the QL muscle. QL2 posterior to the QL muscle outside the middle layer of the transversalis fascia. Okay. For the QL3, anterior to the QL muscle between the QL and the posterior and the psoas major muscle. Weakness for QL1 and QL2 not reported, but there's potential weakness for QL3 because it can spread to the lumbar plexus. Other concern for QL2 is near the arteries, which is posterior to the QL. And the most recent QL is being described is QL3 by Bergam 2013. QL1 described by Blanco in 2007, same with the QL2 described by Blanco in 2007. So the technique, we use low frequency curved array probe, LA, we use 20 to 30 mils per site, and we can either perform single shot or insert catheter. So this is the view that we want to obtain to perform QL block. So we need to identify the at least transverse process and vertebral body and the muscles which near the transverse process, the psoas major, QL, erector spinae muscles at the posterior, and the abdominal muscles. This is the external oblique, internal oblique, and transverse abdominis, and also the latissimus dorsi. So we describe this as a shamrock or thumbs up sign. The thumb corresponds to the transverse process. Okay, so all the other fingers correspond to the psoas major muscles, and this space corresponds to the QL muscle. So for QL3, we target between QL and psoas major. Okay, some describe as a shamrock sign. The transverse process is the stem of this shamrock, okay, and these three leaves corresponds to the QL, psoas, and ESM. So this is the sonor anatomy at the L4 level. The transverse process is here. Anteriorly is the psoas major. QL just at the tip of the transverse process, and posteriorly is the erector spinae muscle. Okay, so this is where we should inject posterior to anterior. Okay, we once we identify the thumbs up sign or shamrock, so we can identify the QL and psoas major muscles. So complications. It can spread to lumbar plexus, so that's why it can cause weakness. Possible to puncture intra-abdominal structures such as the kidney, liver, spleen, and very vascular, can cause hematoma. So lumbar arteries at posterior aspect of the QL muscles. Okay, So this is the last topic, ESP block. So it is described by Ferrero in 2016. He described an interfacial plan block which is successfully treating the severe thoracic neuropathic pain. So the LA is injected deep to the erector spinae muscles on the top of the transverse process. Block work at the origin of the spinal nerves based on the cadaveric and contrast studies. So this is the level where we inject the LA for ESP block. LA deposited near the costotransverse foramen, it's spread to the dorsal ramus, which supplies muscle and skin at the back, and ventral ramus of the intercostal nerve, which supplies the muscles and skin anteriorly. So ESP covers posterior, lateral, and anterior aspects of the hemithorax. Okay, spread longitudinally, intertransverse connective tissues complex is varus. Okay. So when we try to identify our muscles for erector spinal plan block, there are few muscles that we need to identify: the trapezius, rhomboid, and erector spinal muscles. Okay, so we deposit our LA in between the transverse process and erector spinal muscle. And if you can see here, the LA will spill to the paravertebral space. So we can perform in a sitting position, lateral, and also supine position. But I personally like to perform it in a sitting position. Okay, so this is the examples of ESP. First, we try to scan laterally and identify the ribs. Okay, this is at the T5 level, so we can identify the three paraspinal muscle. This is the trapezius, rhomboid, and also the ESM, erector spinal muscles. Okay, so this is the ribs. We can see pleura here. So we need to slide medially. We slide medially and we can identify the costotransverse joint. Here still we can identify the pleura. Okay, and the three muscles here. Once we arrive at the transverse process level, we can identify these three muscles and transverse process: the trapezius, rhomboid, and also erector spinal muscles. So our target is just above the transverse process. Okay. And if we scan medially, we can identify the lamina. So at this level, maybe we can some studies describe as a retrolamina block. Okay, so the good thing about ESP is it can spread quite well. Some later I will explain. Some studies shows that the spread is 4 cranially and 4 level caudally at one, even with one injection. Okay, so if we inject the LA at the T5 level, it can spread up to the T1 till T7. Okay. This is the transverse process parameter view. So here we can identify again 3 muscles and also the transverse process. So here we insert our needle cranial caudally and target above the transverse process. Okay. Once we reach the plane between the transverse process and erector spinal muscles, there will be LA deposited above the transverse process. And once we stop injecting, there will be a pumping effect. The space will collapse. Okay. So in cadaveric studies, like I mentioned just now, 20 mils injected spread a mean of 4.6 intercostal space craniocaudally. One case report, they block at T5 level. It is sufficient to have multi-dermatomal sensory block ranging from T1 to L2. So as I mentioned just now, this ESP can cover anterolateral and posterior aspect. This is when we inject 20 mils at the T5 levels. So this is a plain block, and we depends on the spread of LA to get the effect that we wanted. Okay. So the advantages of erector spinal plain block, it is simple and safe, easy to learn. Sonotomy is easily recognizable. No structures at risk of needle injury in immediate vicinity. We just need to be careful with the pleura, but the pleura is quite far away. And at the transverse process level, the pleura is not in the view. Needle path injection site is distant from the pleura, blood vessels, and neuraxis. For more acceptable in coagulopathic patient compared with epidural, multiple dermatomal coverage, as like I mentioned, anterior, lateral, posterior, have been reported to result in both somatic and visceral analgesia, and we can insert catheter. So let's compare. Epidural is too invasive for clinical setting. Apparent risk of spinal cord nerve injury, dural puncture, epidural abscess, and hematoma. Quite difficult. Okay. What about paravertebral block? Risk of pleural breach and pneumothorax. And the common side effects of paravertebral block is failure, block failure. What about intercostal block? Limited dermatomal cover, need multiple injections, and risk of pneumothorax and higher risk of last. What about pectoral block and serratus plain block? Mainly provide analgesia to the anterolateral chest wall and axilla, no posterior coverage. So multiple uses. Analgesia for thoracic, chest wall, abdominal surgeries, acute or chronic pain conditions. So newer reports says ESP also can be used for spine surgery and hip surgery. So the common indications to perform ESP in ICU is refractures. Okay. Most of the time, once we insert ESP catheter, the pen score become better, and the patient can practice his or her incentive spirometry. Okay, so we can avoid intubation in those kind of patients. For surgery, it is an alternative for PECS or serratus anterior plain block for breast surgeries with axillary limb node dissection. Okay, others like, of course, nephrectomies, hysterectomies, laparoscopic ventral hernia repair, laparotomies, and chronic postherpetic neuralgia. Okay, confused? I hope you are not confused, and you can ask, if you have doubt, you can ask questions after this. And thank you very much.
Okay, thank you so much for the very informative talks. So we open the floor to questions. Any questions from participants? For online viewers, you can type your question in the chat box and we shall answer your question.
Good afternoon, Dr. Khairul.
Yes.
I have a questions on my practice. While for PEC block, we use it usually mostly for mastectomy. Do you ever have a concern of metastasis, like block and metastasis? Are they a concern? And if let's say the tumor, let's say, is very close to like the third rib and fourth rib over the angle where we usually inject, would you still perform a PEC block? And for mastectomy, what is your take on the best approach for analgesic, whether it's a ESP or PEC?
Thank you for the questions. So the evidence for the metastatic after we perform blocks is not strong. We do not have any evidence that saying that after we perform the block that it can metastasize. The second questions, if there's tumor over anterior part of the breast, the alternative that we can perform is serratus anterior or ESP. Okay, so the in my center, usually the surgeon doesn't like us to perform PECS because pre-operatively because it will disturb their surgical field. So usually we will perform ESP to avoid argument with the surgeon. Okay, then the third questions. Okay, so there is no studies to compare PECS, serratus plain block, and ESP say, but from the evidence that I showed, PECS actually is good enough to cover breast surgery such as mastectomy and axillary clearance. But if you have concerns with post-operatively edema and all that, so you can perform other kind of blocks. Yeah. Okay. Is there any questions?
We have a question from our online viewers. So I think continuing on with the mastectomy, the question here is, what's your cocktail? Example, the level, amount, and concentration of LA for ESP, particularly for mastectomy and axillary clearance.
Okay, so ESP, as I mentioned just now, it depends on the spread of your LA. So I tend to give a large volumes, at least 40 mils of, if it's unilateral. If bilateral, of course, I will give 20-20. For the concentration, 0.2% or 0.37% of ropivacaine. Yeah, you also can use levobupivacaine, but of course, it is not in the market anymore. So we only have Ropi at this moment lah. Okay.
There's a lot of questions regarding ESP, so
Okay.
I'll combine this question.
Okay.
So they ask regarding if we insert a catheter for ESP, what is the length of the catheter to be left inside? And also, do you insert a catheter for ESP for mastectomy?
Depends. To insert catheter for mastectomy, ESP, depends on the patient's factor lah. If it's like you assess the patient, then catheter would be beneficial for that patient. Yes, you might. But most of the time, if it's a straightforward case, we just single shot. We just give single shot to the patient, and then how long we need to insert, because our catheter now is a payung catheter. It's like granular kind of catheter, so it is not like a epidural catheter which we can insert the catheter in the space. But previously we use this silver steam. Yeah, silver steam is like a epidural catheter. So usually I will insert like 3 to 5 centimeters in the space. But of course, once again, we must see the spread of our LA.
I also have a question.
Okay.
So for ESP blocks, can we do it like bilaterally? And would it have any complications if we block bilaterally?
Yeah, like I mentioned just now, we can perform it like bilateral rib fractures. Okay, we can insert bilateral catheters. Okay, but we must calculate the toxic dose for the patient. Depends on the weight, right? So, like for example, ropivacaine, we must make sure not exceed 2.5 milligram per kilo. Okay.
Okay, you mentioned earlier that ESP is better for the coagulopathic patients. So what is your cutoff level for ESP? In what parameters?
Okay. Ideally should be INR less than 1.5, of course. But in besides the INR, we also need to know the anticoagulant, right? How long it has been served. Okay, if you need to perform the ESP urgently, you can't wait until certain time to perform. So we can this anticoagulant usually we do not wait for certain amount of time because it is just superficial. Unlike the paravertebral block, of course, I won't touch the patient if it's for paravertebral block because it's a deep block and patient is just on anticoagulant. The INR, as I mentioned, if more more than 1.5, the INR, I will assess the patient and see the risk and benefit ratios. If the benefits outweighs the risk, then I will perform the ESP to the patient. In Pinang, what type of block is commonly performed for the breast surgery? May I know? PECS, is it? Yeah. I mean, PECS is quite easy. Okay, but yeah, usually the thing with PECS, it's with the surgeon. Okay, so that's why sometimes we need to perform ESP. Yeah.
There's one more question from the online viewer. So they want to ask if do you always supplement PECS2 with a PECS1?
Depends on the surgery. If mastectomy, axillary clearance, of course, I will perform PECS2, which is second injection plus PECS1. Yeah. But if it's like pacemaker incision, we just can perform PECS1. But for the this one, BBF, the vascular surgery, we perform second injection plus supraclavicular lah, to cover the T2 area. Because the supraclavicular doesn't cover the T2 dermatomal level, the intercostal brachial nerve.
You did.
Just now the concept is a bit wrong because the question itself is wrong. We don't supplement PECS2 to PECS1. Yeah, okay. PECS2 is basically PECS1 plus the injection. PECS1 is only single injection. So the question is a bit wrong just now. Okay?
Okay. I think when we talk about mastect with axillary clearance, basically we want to focus more on the axilla because that's where patients complain of pain, even in chronic pain clinics. So it is. I think it goes back to the definition of PECS2 block, as Dr. Khairul has mentioned and Dr. Nabila has mentioned. I've noticed that along the years, we always think that, okay, for PECS1 block, there's only one injection. With PECS2 block, there's two injection, and one of it is PECS1. So there's basically Blanco has never named the second injection. So that it is not called PECS2 block. That particular injection is not called PECS2. Okay, so just get the nomenclature right. And there's a difference on the site of where you want to inject for you to perform a PECS2 block for mastectomy and axillary clearance compared to a second injection of that PECS2 block for a vascular access procedures of the axilla or the upper arm. Okay, for mastectomy and axillary clearance, you want to perform the second injection of PECS2 block at the third and fourth rib. But for injections whereby you want to supplement incisions over the upper arm and also the top of the axilla, you want to block the intercostal brachial nerve, which is comes out from the T2 dermatome. So you don't want to block at third, fourth rib for the second injection for a vascular access surgery. You need to block higher up. So I usually go around second or third rib, at least below the second rib. Okay, so that's the difference between the injection sites for the second injection of PECS2 block for a mastectomy and axillary clearance and also a vascular access surgery. So just to get things correctly understandable. So those are the things that you need to look back on, because I think all this while that has been the definition being understood by all the other practitioners, and even in some of the papers also they have mentioned PECS1 injection, PECS2 injection, but it's actually not correct. So just get the concepts right. Then with regards to the question regarding coagulation and blocks, I think it goes back to risk and benefit, as Dr. Khairul has correctly mentioned. If the surgeon feels that the patient warrants a surgery and is fit for surgery, even though the coagulation profile is deranged, I don't see there's any contraindication for block. If they can cut, you can needle. Okay, unless it is at the site where it is deep, it's not compressible, and also where the limb needs to be saved. So for example, let's say for BKA or AKA, there's no issue of any weakness and patient is coagulopathic, okay, but needs the BKA or AKA. Let's say cardiac risk is high or respiratory system is deranged or dysfunctional, then you may consider a block, okay, when there's no other issue of any weakness post procedure. So it has to be seen as a whole. So basically, you need to see and understand the clinical scenario. So I hope that answers the question and clarifies things.
Thank you, Dr. Azrin. Okay, so another question. Would you still give PCA opioids after ESP single shot?
Depends on the surgery. Yeah. So in that context, does the person mention what kind of surgery is that? So basically, the question is how to prolong your blocks lah. So there's a lot of papers to suggest how to prolong your LAs. The most good evidence is dexamethasone, either IV or perineural. So usually I will give IV dexamethasone at 4 to 8 milligram to the patients to prolong the effects of the LA. So basically with this IV DEXA or perineural DEXA, it shows that it can prolong up until to 300 minutes. Okay. So perineural DEXA must be careful because the DEXA got preservatives, so it can be neurotoxic. So it is not a good idea to for our current DEXA in OT, got preservatives, so we shouldn't use that DEXA as a perineural for the LA. So another thing is perineural clonidine or Brisidex. Yeah, but cost is an issue lah, as compared to DEXA is quite cheap. Okay.
I just want to add on to the answer by Dr. Khairul, is that when we talk about we give a patient a regional anesthesia block, especially facial plane blocks lah. Facial plane block doesn't last long one because what is the concept of facial plane block is you're injecting in the plane, hoping that the LA travels along that plane and reaches the nerve at another side. Yeah. So and based on the volume, and so usually we roughly estimate for ESP, single shot ESP to last about maximum 8 hours. Rarely go beyond 12 hours. So then again, and so when do you use this kind of ESPs or that? It's part of a multimodal analgesia technique. Yeah. That like what Dr. Khairul mentioned, if you want to prolong the block, you put catheter lah, you put give IV DEXA. These are good evidence to prolong the block. But then if you treat it as part of multimodal analgesia, then you have to give other modalities combined with PCM, NSAIDs, and to a certain extent, you need some. If you need to use PCA morphine, you still need to use PCA morphine. Then you have to think about but from the perspective of the surgery. If it's just a video-assisted thoracic surgery, maybe and which you think that the pain will only last probably half a day. So the patient only need that small window of about probably 6 to 8 hours of good analgesia. Then after that, they can take oral tramadol or PCM or NSAIDs. Then you just need that small window. Then the block will be okay. Then you don't need PCA. But if you expect the pain to last beyond 12 hours to the next day, then you need to supplement with your PCA morphine. Recently, we had a experience in HKL just last week. We had a 19-year-old girl who has some osteosarcoma with metastasis to the lung. Then the surgeon need to perform bilateral video-assisted thoracoscopy to remove the metastasis nodes. So the surgery was done early in the morning. So as a first case, so we give bilateral ESP, single shot. Then we discharge the patient back to the surgical high dependency unit for observation. Then when the APS review on the first day, no pain, very good. Then the next day, the surgeon asked the patient to do incentive spirometry. She cried, don't want to do because of pain. So yeah, so difficult to say. Our previous experience with VETs, very good. First 6 to 8 hours after that, patient no pain, very good, can perform incentive spirometry. Then then again, pain is a very subjective thing. Different patient, different procedure, and you have to see as a whole. See from the perspective of the procedure, from the perspective of the patient, then you adjust accordingly. But the principle is the same. You want to give facial plane blocks, it's part of multimodal analgesia. Single shot doesn't last long. You can either prolong it by giving IV DEXA, catheter, or you need to combine. If you think that the procedure warrant a longer period of post-operative pain relief, you have to give PCA, you have to give PCA. All right? Thank you.
Another question. What is your comment on doing blocks in pediatrics population and your current practice?
We do perform in pediatric patients. Of course, we perform it when the patient is under GA. Because we also need to practice multimodal analgesia in pediatric populations. The important thing that we need to calculate the dosage, not to exceed the toxic dose. Yeah, and then sometimes we need to make the concentration diluted, because if you give upper limb and lower limb blocks, then in more older children, after we extubate the patient will cry because they complain they cannot move their limbs. Yeah, so not because of the pain, because they cannot move their limbs. So you need to consider those factors, okay? The concentrations, the sites, and not to exceed the toxic dose.
Actually, I have another question. Earlier you mentioned perineural Presidex. So usually how would you give it? Would you mix it with your cocktail, or is a separate injection?
I personally do not have experience, but some people perform. They mix with the LA. It's about one mic, I think. Yeah, of the Presidex. But once you take just because one Presidex is four meals, I think. Yeah, so we just take one. So we just left the 3 meals. So it's the drug itself is expensive. Then for me it's not cost effective.
Okay, thank you, Dr. Khairul.
Okay, thank you very much.
Okay, so we have ended our modules for today. Okay, so to our participants, if you notice there were a lot of booths outside, so there are some vendors with their ultrasounds. You can have a look and hands-on on the ultrasounds. Okay, we'll be having our lunch break and prayer break. Keep in mind for all participants to take all your bags and personal belongings later when you leave, because we will convert this hall later into our hands-on workshop. Okay, now before you go for lunch, can we have a photo session with all the speakers and participants? And also for our virtual participants, this marks the end for the virtual part of the workshop. Thank you for participating to our online participants. Thank you.